And welcome everyone to our next webinar in the series held by the Arab Health Summit by Access. Today's webinar is titled One Piece of the Puzzle, the COVID Vaccines and Our Path to Hope. My name is Madiha Tariq, and I'm the Deputy Director at the Access Community Health and Research Center. We are so excited to be hosting this webinar because especially today's conversation helps link global health to local health. As you know, the US this week surpassed 500,000 COVID-related deaths, and the COVID status of the United States is worse than anywhere else in the world. And one of the things that we support at Access and through our Arab Health Summit is that health has no borders. And in order to fix health issues locally, we must engage in health issues globally. And it is for this reason that we are so excited to host this panel today. Our facilitator for the panel will be Dr. Adnan Hamad. Dr. Adnan Hamad is very near and dear to us. He is the founding director of the Access Community Health and Research Center, and also the founder of the Arab Health Summit, which started about 2 decades ago. And it was his vision to bring together global and local public health leaders to discuss health, to really understand and work together on health issues, because we understand that health has no borders. Dr. Adnan Hamad is also the president and CEO of Global Health Research, and he knows everyone around the world. And if there's anyone who can bring people together to have a productive and educational conversation and help bust all the myths around vaccines and COVID, it is him. So with that, I will hand it over to you, Dr. Adnan. Thank you so much for joining us, and to our wonderful speakers.
Thank you, Madiha. Thank you for your kind words. As you have indicated, I will be moderating this session. I'm so excited about having two of our distinguished speakers, Dr. Alejani and Dr. Rana Hajjeh, that will cover most of the hemisphere when it comes to COVID-19. Globally, as of today, there have been about 113 million confirmed cases of COVID-19, included 2.5 million deaths, and that is really sad for each and every one of our people. I also agree that global health challenges require global health solutions, and epidemiology does not recognize any borders. With that said, I will be introducing our two speakers who will be presenting scientific data each for 20 to 25 minutes, and then I will open the session for a question and answer after these two presentations. Let me start with our good, long-lasting friend, Dr. Alejani. Dr. Alejani is the Dean of College of Public Health at the University of Nebraska Medical Center and a former Assistant Surgeon General with the U.S. Public Health Services. Dr. Khan's professional career has focused on health security, global health, and emerging infectious diseases. He completed a 23 years career as a senior director at the Centers for Disease Control and Prevention, which he joined as a disease detective, and where he led and responded to numerous high-profile domestic and international public emergencies. Dr. Khan was the main architect, the main player of CDC National Health Security Program, and continues this work at the University of Nebraska Medical Center. As Dean of the University of Medical Center College of Public Health, his focus is on health system and community-based transformation. Dr. Khan received his medical degree from the State of University in New York Downstate Medical Center, and has a Master of Public Health from Emory University School of Public Health. And he completed his pediatric and internal medicine training at the University of Michigan at Michigan State. Dr. Rana Hajjeh is a dear friend and a wonderful person who really served the MENA region and the U.S. at different times. Dr. Hajjeh is a senior public health leader with a 25 years experience in global health policy and diplomacy, and health management, especially in the Middle East region. Dr. Hajjeh is currently the Director of Program Management at the WHO Eastern Mediterranean Region Office. In her capacity as the Director of a Program, she directs and leads the technical public health programs at the regional level, including university health coverage and system, communicable and non-communicable diseases, information, and science. Prior to that position, Dr. Hajjeh was holding the position of Director of the Department of Communicable Diseases Prevention and Control. In this capacity, she played a major role in supporting emergency response in the region. Prior to joining WHO IMRO, Dr. Hajjeh was working with the US Center for Disease Prevention and Control for 23 years, where she held many senior positions with increasing complex management responsibilities and worked extensively in the Middle East region. Dr. Hajjeh holds a medical doctor degree from the American University of Beirut, Lebanon, and has benefited from extensive training in medicine, including the US Federal Employee, and she received many awards, including the prestigious US Federal Employee of the Year Award in 2014. I like to ask you to welcome our two distinguished speakers, and now we'll start with Dr. Alejani Presentation.
Good day, everybody, and thank you very much for the opportunity to speak to you today about COVID and vaccines. Thank you, Dr. Hamad, for the introduction. And I must say, it's taken me many years to be on the same platform with Dr. Hajjeh, so that's a unique pleasure to be permitted at this point in my career to be on a panel with her. Let's just say we've known each other for a long time. I won't say how long because she looks way too young at this point. So let me share my screen. Please, can I get a thumbs up or a yes if people can see my screen?
Yes.
Okay, excellent. So I'm going to talk about hope. And so I'll try to make this brief because I want to leave plenty of time for questions. I'll talk a little bit about the state of COVID-19 domestically here in the United States and worldwide, spend most of my time on vaccination, and I think I'll leave maybe some of my final thoughts to a Q&A. So what we know and what we unfortunately continue to fail to learn after decades of experiences with emerging infectious diseases. As you just heard, a disease that we did not exist or we didn't know about 13 months ago, over 112 million cases worldwide and 2.5 million deaths. Tragically, the United States, which only accounts for 4% of the global population, has 25% of all cases and 25% of deaths. So definitely a disproportionate impact in the US compared to its population. I showed this slide for a couple of purposes. One is to make the point that this is a pandemic, which means it's everywhere, worldwide. And you'll see the disease based on a color code spread worldwide. I'd be very cautious about what we're seeing in many countries in Africa due to reporting issues. And we've seen some good data recently out of Zambia that sort of supports the fact that we don't have really good reporting due to testing issues in Africa. However, I do want to point out some of these countries, China, New Zealand, Australia, and remind people that there are currently 1.7 billion people in the world who wake up with hardly any cases or any deaths without a vaccine. So again, that hope part. So it's not just vaccines that are hope, but it's public health that is hope. Here in the United States, the outbreak has been extremely unusual. I have called it a staircase outbreak, something in my 30 years of public health experience I've not seen, where one wave leads to a second wave, leads to a third and fourth wave. where each wave causes more cases than the last, and you never actually come down. So that's why I call it a staircase outbreak, because you never go down, you just keep going up. Even now in the US, where we're so fortunate to have this dramatic decline since the beginning of the year, mirrored elsewhere in the world, not just in the US, you'll notice that we seem to be leveling off in the US, but leveling off at a level that we thought was way too high back in the summer in the United States. So still over 200 cases per million here. Let's see, what else do I have for you? So let's talk about vaccines, which is what I want to spend most of my time, and then transition to Dr. Hajjeh to talk about what's going on worldwide. And when I talk about vaccines, I talk about safety and efficacy, but I also talk about trust, because vaccines that aren't trusted are useless. And so a lot of time I'll talk about why trust is important. I also love this slide about hope. This is a church blessing COVID-19 vaccines in Houston, Texas, in the United States. So I think a nice juxtaposition of science and religion to give us hope. Before I talk about vaccines, I want to remind everybody, and I do this in every talk, that public health is also a source for hope. And in the East, where they tested, traced, and controlled disease, so the New Zealand, Australia's of the world, where they're having, for example, the recent Australian Open with lots of fans in stadiums and no masks, they took a different public health approach compared to most parts of the world, where they delayed, debated, and divided. And to be honest with you, we spent more time fighting each other than we spent fighting the virus here in the United States. So this is about public health choices on how we respond to this disease. Importantly, what it says to me is that if you can use masks, social distancing, hand washing to decrease disease or to very low levels in communities, if you add vaccine to that, so much better. That just gives you one more tool. So now we have an additional tool to get disease down within our communities, coupled with the existing public health tool. So it's all good news here about trying to really crush this disease within our communities. The other good piece of news besides the role of public health, as I said, is vaccines. We have about 100 vaccines in various stages of development, many of which have been fully approved or are already in use in some countries, and many others that are lined up to potentially make their way to widespread use. I always show that there's 4 vaccines that were abandoned. And the reason goes back to trust, to tell people that not any vaccine got approved. You had to be safe and efficacious to get approved. And so I like to remind people that there are vaccines that did not make it through this gauntlet of testing because they just weren't good, and to reassure people. And I also use this slide to reassure people, because many people think that, well, the vaccine was rushed and therefore corners were cut, and this isn't a safe and effective vaccine. So I always use this slide to remind people that there was, in these circumstances, we already knew what the virus was. We already had this platform, the mRNA, messenger RNA platform to make vaccines available. We already had that platform ready. Money was not an issue. All of these trials started very quickly. It was easy for them to enroll people. And then we also use electronic health records. So instead of using paper forms, things were moved through electronic forms. And also our regulatory agencies were partners instead of stumbling blocks with these drug companies to make these vaccines. So at the end of the day, phase 1, phase 2, phase 3 trials, everything was done the way you would expect in any other vaccine product. And if anything, there's more transparency with these trials than there's ever been with any other drug, where you can actually go look up the whole protocol if you would like to about these drugs. So again, to be able to trust that these are safe and efficacious. I can leave this if people want me to talk about it during the Q&A, but the bottom line is, routinely a virus enters your body and you eventually develop an immune response. And there's multiple ways to do this artificially, either with often you just you kill the virus, or you chop up the virus, give it to a person, and they develop an immune response. But there are better ways to do that now, which is to use your own body to make pieces of the virus and then cause the immune response. And that's all these mRNA vaccines do. Essentially, they go into your cell and they go, okay, let me just make this piece of the virus and give you an immune response. So it sort of shortcuts some of putting the live virus or a killed virus in you, is just put the piece in you that creates the nice immune response. They're currently licensed in the United States 2 vaccines, the Pfizer and the Moderna vaccine. Both of these use the same messenger RNA platform. They're highly efficacious. Thanks to some new rules, they can be stored either at freezer or refrigeration temperature. The side effects are the typical injection site side effects. We know that more serious side effects are less than 4.5 per million at this point, with the data on 45 million people. So these are actually very, very safe vaccines. Here's the data on 4.5 million doses and 4.5 million cases per dose administered. So again, very safe vaccines currently, and the majority of the side effects are are the bump in the arm and the low grade fever sort of stuff. Let me make a few points about the mRNA vaccine, because while today the big issue worldwide is supply and not having enough vaccine, eventually we'll need to address people's confidence. And to address people's confidence in this vaccine, I like to remind people that these have been rigorously tested. The technology is not new. They don't contain a live virus. This vaccine does not make its way into your cells, into your nucleus of your cells. It doesn't change your DNA. It doesn't cause infertility. There's no microchip in this. There's no, people had previously said there was a luciferase gene, which is a gene in fireflies. This will not make you glow. So again, a very safe, effective vaccine. Besides these 2 vaccines, using the mRNA vaccine, there are a couple of vaccines that use a different strategy. And essentially, they use a virus to put a piece of DNA in your body, and that DNA then creates the protein that's necessary for your immune response. So again, making it a little bit faster process than giving you the killed virus itself. There's 4 vaccines that use this adenovirus strategy. Again, this is a proven strategy. We have a proven Ebola vaccine using this strategy. So again, nothing new here, just with the enough resources to be able to make these vaccines in a quick fashion. Nothing much here. The big thing for Johnson & Johnson, we expect its approval in the United States, hopefully this weekend. The good news is here that out 4 to 6 weeks, 100% decrease in deaths. So by the time you're out about 4 to 5 weeks, nobody will get hospitalized and nobody will die. So this Johnson & Johnson vaccine is also an excellent vaccine that hopefully will be available shortly in the US. The other vaccine that's currently available worldwide and is scheduled for discussion in the US sometime in March and April is the Astrazeneca vaccine. This has an advantage of being stored at refrigeration temperature. Everything suggests that this is also very safe. So we're looking forward to the AstraZeneca vaccine also. Let me switch to where these vaccines are being used. The number in the box is how many countries are using these vaccines. So you'll see 61 countries are using Pfizer, 41 Oxford, 27 Moderna, et cetera, and then there's the Chinese Sinovac vaccines, the Russian Sputnik 5 vaccine, and then the indigenous Indian vaccine, Covax. Let me finish with some comments about the status of vaccination worldwide. The US is vaccinated approximately 1.7 million people per day, and which is very close to the number of doses that are available in the US. And the expectation is, at least in the US, so for those of you, I know everybody listening in today is for the most part from the US, the expectation is that in 60 to 90 days, anybody in the US who wants to get vaccinated will be able to get vaccinated. And the United States government has already bought over 300 million doses of both Pfizer and Moderna, and we expect 100 million doses of J&J, which is a single dose. So there will be more than enough vaccine by the summer for everybody in the US. And that's even before Novavax and AstraZeneca, 2 other vaccines, may well be supplied. Now, the good news with these, and I love to show this slide to reassure people. So this looks at cases, deaths for everybody, and deaths in nursing homes. So in red is deaths in nursing home. And notice the dramatic drop of deaths in nursing homes since we started vaccinating people in nursing homes. So this is now real world evidence that these vaccines work. It's not just from clinical trials anymore. And I can show you similar evidence from Europe and England especially that shows this dramatic drop in deaths. So the hope is that in the US, 80% of people who die are 65 and older. Almost everybody in the US 65 and older is now eligible for vaccination. So we should at least account for 80% of all deaths in America. So hopefully the dying in the US will stop. This shows you globally, Israel is leading the pack in the percentage of population that is vaccinated, and the United Arab Emirates is actually coming in at second. So this gives you a little sense of what's going on in the world. This is another way to look at what's going on in the world. So the US has dispensed the most vaccine so far at 65 million for a global total of 209 million. So there's 90 countries that are administering vaccine at this point for an average of 6.2 million doses per day. Now that may sound a lot, and it's a good time to talk about the transition to global health. But the bottom line is there's 100 countries that have not yet received a single dose of vaccine. 100 countries. That's unacceptable by so many different criteria. And I'm excited as everybody. You'll see here an image of vaccine going to, I believe, oh, maybe it's not this image, but there should be an image. Oh, here it is, Ghana. So the COVAX initiative is starting to send vaccine worldwide. But the honest truth is this slide, which is that at the current rate of vaccination, it's going to take 3 years and 8 months to vaccinate everybody globally, unless there's a complete shift in how we think about production and distribution worldwide. And this is even before accounting for new variants, which may require yearly vaccination to occur. So we need some brand new strategies. And I hope maybe during the Q&A, we can talk about some brand new strategies. Let me just stop there because I'm looking forward to listening to Dr. Hajjeh myself. I talk about hope. And I've decided I'm going to replace hope with a U, because the critical element in hope is you. And you know, we spend a lot of time, I know I've spent a lot of time talking about super spreaders over the last year, and I'm hoping that all of you who are listening to me today can become hope super spreaders, because that works also. All right, thank you. I'll release my slides and turn it back to you, Dr. Hamad.
Thank you, Dr. Khan. Thank you for well-illustrated presentation. Your scientific facts and contributions are highly appreciated. Dr. Rana Hajjeh, since you know that Michigan is the host of the largest Middle Eastern communities outside the Middle East after Paris, France, I know that your presentation has a lot of expectations from our community, and we are looking forward to learn about the challenges and hope that you are experiencing in the MENA region as well. Dr. Hajjeh?
Yes, thank you very much. Sabah al-khair, everyone. It's great to be with you. Thank you very much, Adnan, for the invite. Can you hear me clearly before I go on?
Yes.
I have a new camera, so I just wanted to make sure it works. Okay, great. And you can see my slides as well?
Yes.
Okay, Great, excellent. And I really like the title, actually, as Ali said. And Ali, it is a privilege to be with you also. It's been a while. We were colleagues at CDC, and it's always good to connect again. Hopefully, we will meet again in person. Excuse me. I really like the title of this webinar, because we have to have hope. We have to have hope in the middle of all of this. And as I put in my title, actually, even though this has been in my whole career as an infectious disease epidemiologist, I have not seen anything like that. But there hasn't been a year that has brought so much attention to health and to public health, but to health overall. Now everybody is talking about health. The focus has been on the prevention. Even things that we as infectious disease physician and public health professionals use to deal with, terms like PCR and all the vaccines methodologies and sequencing and all of this. Now it's a common, household, they are common household words. So I think, we have, unfortunately, we have to have something like COVID pandemic to reach that level. But to me, it is the worst of times, and it's the best of times as well, in terms of the attention this has brought to the importance of public health and the importance overall of being well prepared to deal with pandemics in general. So, I wasn't really sure. Adnan said, just talk about what you guys are doing with vaccines in the region and some of the concerns. So I have probably a few more slides. I apologize in advance if I go through some of them quickly, but I wanted to use some of them for illustrative purposes, just to give you an idea also what it takes to get these vaccines to countries, because it's a very complex process actually for vaccines to reach the countries. Let me see here if I can just go on to a slide. Yes. You can still see the slides clearly. So I'll give a brief update on where we are in the region, in EMRO, with numbers, the status of COVID vaccines, what we are doing as WHO, COVAX, and the support to countries, some of the major challenges, and then moving forward. So I think many of you know the Eastern Mediterranean region, but it's a bit of unusual mix of countries. We do cover, as you see here, 22 countries. Most of the Arab world is actually under the EMRO region. But we also have, in addition to that, we have Pakistan, Afghanistan, and Iran. So we have a big chunk. We have a population of about 700 million, which is about 9% of the global population. But also what is a unique feature of our region, although we do keep hope despite that, is we are probably one of the most troubled regions in terms of conflict and emergencies. And that's another reason why we were terrified when the COVID-19 pandemic started, because we know that in some of our countries that have been in protracted conflicts and wars for years, their health systems had been so weakened that if the virus really spread, it would be very difficult to control it, and the systems will be quickly overwhelmed, knowing that this pandemic has really overwhelmed even the best systems in the world. We also have, we are known to have a lot of low-income labor migrants in many of our countries, because especially for our Gulf countries where these migrants were actually helping a lot developing these countries. And this is where the outbreak focused initially. But also we have a lot of refugees, and 40% of the world refugees are actually in this region now, which is a lot. And these people are vulnerable, they have poor health. We have big countries now like Yemen, like Somalia, like Syria, where we have a lot of issues. So I won't go on about the region, but I wanted to put that in context, the pandemic in context of that regional health systems situation. So overall, Ali went through some of the slides, so I won't go quickly, but just to say that actually in the region early on, we had relatively a slow start. So we were probably the fourth region, as you see here, in terms of numbers. And we had a very early start for various reasons. There was a quick implementation of the measures. But then I'll show you an evolution slide in a minute. Then things started escalating. And right now we're one of the regions where, actually we're one of the few regions where the numbers of cases and death are not decreasing. We are seeing a hopeful decline now globally. Probably part of it is due to the vaccine. This is again, we follow the all the epidemic in the other regions. This is where we stand. I mean, in our region, we have one of our countries, Iran, is among the top 10. We follow very closely the epidemiology of the disease in all of our 22 countries. And this is where we are now in a very quick snapshots. We have crossed the 6 million cases. A couple of weeks ago, we're almost at 150,000 deaths. But we have, on the other hand, 13 countries in our region that started vaccinating, which is, again, a good sign. It's a sign of hope. Wanted to show you, I mean, this is really, I like this slide a lot because it shows the evolution of the pandemic and how the implementation of the measures early on helped, but also how as loosening of some of these restrictions happened, as some of the big religious events like Ramadan took place, we saw various peaks. And I'm saying that because Ramadan is coming up in a month or so, in 6 weeks. So that's, we need to be careful and stay the course, even though we know we're all tired of these measures. That's the global timeline. I think by now you're all familiar with it. I mean, the one piece I want to mention, which is the last data point here, which is in December, actually late in December, we have the first country in our region started vaccinating, and it was Bahrain at the time. So moving on to COVID vaccine, I think, Ali covered a lot of the vaccine specific issues in terms of vaccine development. And again, I mean, speaking of hope, I've been working, on vaccines in my career probably since 2003, 2004, almost now 20 years. I've never seen anything happening like this year. Within a year, basically, we went from no vaccine to a vaccine actually being given to people. Just around this time in February of 2020 is when WHO gathered all the global experts, both on vaccinology as well as on also coronaviruses, et cetera. And they came up with the requirements for what would be considered a good COVID-19 vaccine. So it was just February of 2020, a vaccine was actually basically created from scratch. Many vaccines went through trials, manufacturers, the licensing, the reviews, et cetera. And it's being implemented now to millions and millions of people. This is really unprecedented, and it's great, but at the same time, this is the reason we are also seeing some of the challenges, because it's unusual. Usually countries have a little bit more time to prepare, especially in terms of all the infrastructure needed to introduce the vaccines. So just a word about SAGE, for people who are not familiar with it. SAGE is basically equivalent to the US ACIP, the Advisory Committee for Immunization Practices, that is hosted by the US CDC. SAGE is our strategic advisory group of experts on immunization, and they are the ones who usually review all the data, and they also give the recommendations to WHO and as such globally, whether a vaccine is considered both effective, efficacious, as well as safe. I mean, these are two major criteria we take into account. And, honestly, before our process was a bit slow because we are very thorough and we want to make sure we have all the data needed. So this has been going on much faster than usual. This year, and they had their first meeting actually, very early in before the end of the year, and then they kept actually going through the holidays. But also, I want to differentiate between the recommendation of SAGE and then the process of what we in normal times we call pre-qualifications, where we basically give almost like a license for countries to be used in different parts of the world. Now, because of the emergency, we are doing kind of an accelerated process that is called Emergency Use Listing, or EUL, that WHO is doing. And we are basically considering either EUL or an approval by another regulatory authority that we consider stringent, like the US FDA, the European EMEA. If a country, because countries also sometimes don't have very rapid regulatory processes, so if they want to use, if WHO has not yet issued the EUL, they can also rely on these stringent regulatory authorities approvals. I want to talk about something that is very important for us, but also is really one of the main concerns. I know people are very concerned about access, about equity. As I mentioned, in our region in particular, we have 40 million refugees or more, and it's very important for us that these refugees get the vaccines at the same time as also the other people in the country. But these are some of the principles. So SAGE, I just wanted to give people an idea about how thorough was the process that SAGE followed, WHO, and with all its partners and groups of experts. And they use 6 criteria to take into account when making decisions about vaccines, including, of course, human well-being, but also global equity, also reciprocity, and overall national equity as well. I won't go through this, but these are part of the painful things we had to go through. In addition to having a framework for these values that I talked about earlier, there was a roadmap for prioritizing the vaccines. And of course, then at the end was the vaccine special recommendations, which is happening one at a time. But the prioritization roadmap is very critical because these are basically the criteria used by COVAX to decide that for the first for the first year, we're going to give the vaccine to only 20% of the population who's considered high risk. Excuse me. I won't go through this, but again, this is part of the prioritization roadmap process that we had to go through, because it also depends on the epidemiologic situation. For countries where the pandemic is not progressing very rapidly or the morbidity and mortality is not very high, they will not get the same priority as well. And also, because of the vaccine supply concerns, and there's a huge pressure on the vaccine manufacturers. We had different stages, including stage 1 with very limited availability. But then as the vaccine production ramps up, there will be more access to these vaccines. And I hope, Ali, it won't take us 3 years to get at least to all the countries. I think you've been hearing a lot about COVAX, and COVAX is one of these innovative ideas that WHO, Gavi, WHO and its partners. So for COVAX in particular, which is the facility responsible for vaccine procurement and allocations, there was WHO, Gavi, which is the Global Alliance for Vaccine Immunization, that usually covered vaccines in low-income countries, and CEPI, which is a US-based organization that worked on research and preparedness for epidemics. They basically divided countries either into what they called advanced market commitment, and these countries would include basically low-income countries. Many of those used to be Gavi eligible before, i.e. they were getting the vaccine subsidized, in addition to a few other countries that are also low middle income. And then there are the fully self-financing countries that are paying for the vaccine without the additional assistance. In our region, we are very happy. I mean, I have to say, I'm really, overall, despite our limitations, I'm proud overall of the way the region responded to the pandemic, the interest that we got for all various initiatives. So even though many of our countries have the full capacity to buy on their own, they also enrolled in COVAX, all 22 countries. 11 of them are self-financing, but then Gavi can also still negotiate the vaccine on their behalf. And then 11 are what we call advanced market commitment. This doesn't mean that some of the countries that can procure on their own are not doing bilateral deals. Actually, many of them did, but at the same time, they contributed to COVAX, which is important because they basically pooled the funding so that everyone can benefit from it, and it gives an incentive to the companies to start producing. This is also a complex process, but there's a lot of requirements that countries need to have in place before a vaccine can be sent to the countries. They need to have what we call, I think it's in the next slide, they need to have, of course, the regulatory approval. So the regulatory authority in each country has to say, we approve this vaccine before it is shipped. They need to have what we are calling vaccine assessment tool to see if everything is good, because, as Ali mentioned, some vaccines require a very strict cold chain, much lower temperatures than we've ever had. Some of them, some countries don't have the capacity really to receive all these vaccines. So there are lots of things. And then the one thing that has been quite complicated, I don't know if this is, this is partly covered here, is what we, as part of this vaccine deployment plan, countries need to have what we call indemnification and liability forms signed before the company agrees to send them the vaccine. And the reason this is happening is because the vaccines this year were developed very quickly. The companies felt that they cannot bear all the liability, and they wanted the countries to sign indemnification forms in order to also share the responsibility with the manufacturers in case there are any adverse events happening. And this is because basically for most vaccines, they were only able to monitor the adverse events for about 3 to 4 months. But the good news is that throughout this time, the side effects, there were really very minor serious side effects. And now that also millions of people are being vaccinated with various vaccines, we continue to see very, very low rates of adverse events, which is also very, very important. I'm going to start going a bit quickly, but Ali already mentioned the cold chain. I want to say that having the mRNA vaccines requiring -70 cold chain, or what we call the ultra cold chain, is very, very unusual. Most countries in our region did not have this capacity to actually have these vaccines. And sometimes, even if they're able to procure the freezers, for example, at the national level, it's very hard to make sure that same capacity exists at the sub-national levels in the provinces, et cetera. So this has been one of the major challenges in terms of that. What we are doing to support the countries, again, we've been doing a lot of work to help them with all these forms, developing the plans, the assessment tools. We are monitoring very closely country regulatory authority. We are supporting the regulatory authorities in the countries to go quickly issuing these licenses. And also we are working very, very closely with COVAX to determine allocations of the vaccine to ensure this fair allocation. And you probably heard Dr. Tedros, DG, a couple of weeks ago when we had our executive board meeting. He made a promise that by April 7th, which is World Health Day, he wants everyone, all countries, to have received at least some vaccines. So we have a lot of work ahead of us, but we are hoping, we're still hoping to make that deadline. Things are starting to roll. A slow start, as I mentioned, because of all the forms and all the legal requirements. I won't go through the details, but to say that for WHO, we are monitoring, it's not about supporting the vaccine introduction, but to having good surveillance systems in place to monitor adverse events, to do all the immunization work, as I mentioned, the regulatory work, as well. This time also, we're doing a lot of work on communications because of the rumors and all the vaccine hesitancy issues and the questions people have. Of course, a lot of challenges at all levels with country readiness. For COVAX, countries had to make a financial commitment and actually make an advance payment to COVAX, which for many countries, countries that didn't account for it in their budget. This is not how they operate when they buy vaccines. So that posed a lot of issues. Fortunately, most countries were able to deal with that. The legal issues are still a bit complex. It's a bottleneck, but we're getting better. We negotiated special deals. Actually, just yesterday, we managed to have 2 more countries in the region agreeing to do that. The regulatory approvals, as I mentioned, all the immunization systems, and then the community engagement, like we had for the pandemic also is a huge issue. Just to give you an idea, when we started, which was December 2020, so about 2 months ago, a little bit over 2 months ago, most of our countries, this is just a snapshot from few countries in the region, they were really not ready for many of the criteria they needed for the vaccine introduction. So huge progress in 2 months. This one I won't go through. Ali covered all of the vaccines, but we monitor, of course, very closely when the WHO will issue the EUL, when a SAGE meeting. So for now, we have only 3 vaccines with the EUL, which is Pfizer, BioNTech, and then the Astrazeneca, both Astrazeneca vaccines. But there are other additional vaccines approved by the other stringent authorities. As you see here, I mean, this is some of the expected or projected supply for our region. We are hoping, of course, we are starting slow, but we are hoping that by 2022, we should have most of the region hopefully having access to this. I'm going to go through it. These are the vaccines with the EUL. Again, Ali covered that. In our region, we have the UAE. It's so far they have administered about 5 million doses. So probably, I mean, maybe 2.5 million people have been vaccinated. We are monitoring all our countries very closely. As you see here, we have 13 countries, as I mentioned, and the 8 countries that have not yet started, they are supposed, we have 2 or 3 of them, actually 5, including Sudan, now Djibouti, and Tunisia and Somalia have received confirmation that they will get vaccines within the next month. So we're hoping that by April, all of them would have at least received some vaccines. And that's the same tracking sheet. This is just to give you an idea about how closely we are following the situation in each country in terms of all the requirements, including the import license, which also is something the countries need to manage to do. Last but not least, a couple of words about monitoring adverse events. In the region, this was one of our weaknesses because countries don't always report on adverse events. So we are strengthening the adverse events reporting systems because it's a requirement for these vaccines. And we are monitoring very closely depending, this is where sharing, when countries share data with us, it makes our job a lot easier. But we are getting data regularly from countries and we are monitoring how many adverse events. So far, very little, we are very thankful, alhamdulillah, that per 100,000 doses given, we are seeing almost no serious side events so far and only minor adverse events. I wanted to say a word because I think for this audience is important. People were asking, why don't we have vaccine production in our region? And unfortunately, over the last 20 years, the region actually went back. Many of the countries that used to produce the vaccines stopped. Now we have very few countries in the region that have that capacity to do that. But this is one of our big plans, is to revamp vaccine production in the region as well as technology transfer. Mm-hmm. And one last thing is that we are watching very closely what's going on in the community. We are monitoring social media. We are doing surveys. We are trying to see developing a lot of talking points and Q&As. And actually just we made a short video I should share with you as soon as it's available last week, because we made it in English and in Arabic, and I was part of the Arabic one. So hopefully we will have that you could share also with the community in the US if it can be of any help. So moving on, I mean, as I mentioned, again, it's worst of times, but best of times. This pandemic has tested us to the limits. It was a very big stress test. It uncovered a lot of our weaknesses, gaps in health systems, but we do see the end of the tunnel. We see the light at the end of the tunnel. We think the vaccines are great, but the vaccines by themselves are not enough. It's going to take a while for them to to roll out, and people need to stick to all the other interventions that have proven to work, the masks, hygiene, etc., and avoiding the gathering, as well at the level of the countries, the early detection, isolation. I really think it's critical to take advantage of this momentum that the pandemic created and to make sure we are better prepared for whatever the next emergency by focusing on strengthening our health systems, working with our partners, multi-sectoral collaboration, in particular systems for vaccine production and immunization systems in the region. And to end, I just want to emphasize again that really, and it's not just a slogan, no one is safe until all are safe. If one country continues to have a major pandemic, or if a subgroup of vulnerable people or refugees continue to have the pandemic, everyone will continue to suffer. So with that, I think the need for all of us to pull together the regional and global collaboration are critical. So thank you so much for your attention.
Thank you, Dr. Rana, for a very important information for our audience worldwide. I would like to ask some questions for you and Dr. Khan. Dr. Khan, you may present your concluding remarks with one of these questions, but I have one question for Dr. Rana Hajjeh and one question for Dr. Khan. The question for Dr. Khan, can you talk about COVID vaccine passport and the way getting the vaccine might impact traveling? And the question for Dr. Rana Hajjeh, are the one-dose vaccine less effective than the two-dose vaccine? Dr. Khan?
So thank you very much, Dr. Hamad. So vaccine passports remain very controversial across the world, actually, but are being proposed to be used, and there's current agreements in a number of countries to use them to allow transport between countries if you've been fully vaccinated. There's a couple of issues. The first is about equity, to be very honest with you. We just showed how much of the world that cannot show a vaccine passport. So essentially, are we locking out a big chunk of the world from travel and other commercial activities? Although this vaccine passport could be supplemented with an infection passport. The other issue is, how long does vaccination last, right? Is it 3 months? Is it 6 months? Is it 9 months? Is it a year? And I think there needs to be some more work to define the length of protection before we start all showing our vaccine passports. And the final issue is a technical issue that can be solved, which is we've seen how people have forged test results to say that they're vaccinated, that they have a positive or negative test. We'd have to think of what are appropriate tools in place to validate any such vaccine passports also.
Thank you, Dr. Khan. Dr. Rana, are the one-dose vaccine less effective than the two-dose vaccine?
No, of course not. I mean, this is not how we judge if a vaccine is effective or not. I mean, there are many vaccines that we take now regularly in our normal life for other diseases that are one-dose vaccines. It just happens that depending on the methodology and depending on how these vaccines were developed, some vaccines require 2 doses. Some of them, like now, the Johnson & Johnson one is coming up as 1 dose, are 1 doses. We still don't know the long-lasting impact or the immunity that people will develop to these vaccines. So it's really, I haven't yet taken the vaccine, so that, as UN, we're not favoring ourselves, although many of us are frontline workers. We've been going to a lot of countries to support the pandemic, but when people ask me, I say I will take whatever vaccine that is approved by the regulatory authority that comes here first. So that's how I think I would trust as I said earlier, the capacity of both the regulatory authorities, WHO, other stringent authorities to make that determination based on efficacy overall and safety. Doesn't matter if it's 1 dose or 2 doses.
Thank you, Dr. Rana. And before I go to Dr. Khan, concluding remarks, I do have another question for you, Dr. Rana. A lot of us care about the underserved people, those people from the 100 countries that Dr. Khan talked about that they did not even enter the vaccination process. Dr. Rana, 51% of refugees worldwide, as you said, they actually reside in the MENA region. What are you doing as IMRO, WHO, for those refugees? Who is taking care of those refugees in the MENA region?
Yeah, thank you. This is a very good question, and of course, I mean, it's not just EMRO. I mean, it's the whole the world really is taking care of them. COVAX. So a couple of things. As you heard you heard the Secretary General Guterres asking to avoid the vaccine nationalism and for countries to include everyone who's in their countries and the vaccination plans. Actually, as part of these national vaccine deployment plans I talked about, countries are asked to put at least all the legal refugees, because if they're not registered, it's hard to capture, but they are asked to account for all the people who live in their countries, migrants, refugees, internally displaced. Others are supposed to be part of these plans. And actually, we've seen this happening already in many countries, that started vaccinating in Palestine and Jordan and Lebanon. And the other thing is that as part of COVAX, COVAX is allocating 5% what we call the humanitarian buffer. So in case, some of these populations, because there are some gray areas, like part of sometimes the countries that are not under the government control or areas where you cannot have access to the vaccine. So COVAX will allocate 5% of the global vaccine supply as what we call humanitarian buffer.
Thank you, Dr. Rana. Dr. Khan, could you please, I want to give you the floor again and maybe highlight some of the concluding remarks that you wish to conclude for less than 5 minutes, but could you kindly give us an answer for a question, which is, can people who are vaccinated still pass on COVID to others?
That is an excellent question about whether vaccine prevents disease transmission versus whether it prevents you from getting infected. We know that the disease, depending on the vaccine, it prevents mild to moderate disease in individuals. There's very good reason to believe that if you don't develop the disease, you are less likely to transmit it. And there's some data coming out from Astrazeneca that seems to prove that. This is usually determined not in the individual vaccine phase 1, phase 2, and phase 3 trials, but it's determined at a community level when you start vaccinating people, and then you sort of can determine at that point, yes, the people who weren't vaccinated are also not getting infected, so likely you are preventing transmission of the disease. Most of our vaccines do also prevent transmission of disease within their communities, so there's no reason to expect that these do not do so also. So again, I tell people, get vaccinated. There's lots of reasons people can come up with around vaccine confidence to not get vaccinated. That would not be a reason to not get vaccinated. And I would go back to Dr. Hajjeh, get the first vaccine that's available to you, regardless of what it is, right? If it's approved, roll up your sleeve and say, thank you, please. All of them show that about 4 weeks out from either the second or the first dose, there's 100% reduction in hospitalization and 100% reduction in death. As far as I'm concerned, that's a really good vaccine.
Okay. Thank you, Dr. Khan. With that said, I want to thank our two distinguished speakers for their scientific contribution on time this morning, U.S. time. We are very grateful for your insight and contribution to the public. Again, I wanted to remind us that vaccine is not the ultimate solution, but public health is still a source of hope. As Dr. Khan mentioned, our next webinar is going to be on refugees and COVID next month. And until then, we will meet you. And thank you again for all your participation from from around the globe. Thank you.
Mask on, America and the world.
Thank you.
Bye-bye.
Thank you, Dr.
Okay, bye-bye. Thank you. Thank you all. Salam. Bye.
Thank you.